Today's case is a 71-year-old man scheduled for primary total knee arthroplasty. What's planned for this patient is spinal anesthesia, multimodal analgesia, and you're planning a femoral triangle block. Quadriceps strength matters, and early mobilization also matters. But here's the issue. Despite good anterior knee coverage, the patient still complains of deep posterior knee pain postoperatively. So the question becomes, do we do another block? Or are we just adding complexity without benefit? And here's where we need to talk about the Popliteal Plexus Block. Now let's get into the study. Here's the clinical problem. What we already know is the Adductor canal block and Femoral Triangle Block preserve quadriceps strength, but neither reliably covers the posterior knee innervation. The posterior pain is what really drives the opioid use after TKA. Now, the previous feasibility data suggested that Popliteal Plexus Block might help, but until now, we did not have a randomized controlled trials. So this study, in this episode that we're talking about, will discuss the main findings from the randomized trial data from Sorensen and colleagues published in the Regional Anesthesia and Pain Medicine in 2025. We're talking about 165 patients enrolled in a trial that received primary unilateral TKA, all under spinal anesthesia, divided into 3 groups. First group, Popliteal Plexus Block plus Femoral Triangle Block. Second group, Femoral Triangle Block alone. And third group, Adductor canal block alone. So everyone received standardized multimodal analgesia and IV PCA oxycodone, but the primary outcome was 24-hour postoperative opioid consumption. Secondary outcomes, pain scores at rest and movement, quadriceps and lower leg strength, timed up and go test, mobilization, and a motor impairment. And here's the key result. Adding a Popliteal Plexus Block reduced 24-hour opioid consumption. The median opioid use was 6 milligrams in Popliteal Plexus plus Femoral Triangle Block group, 10 milligrams, almost twice as much, with Femoral Triangle Block alone, and 12 milligrams with Adductor canal block alone. So that's about 4 to 6 milligrams reduction of IV oxycodone in the first 24 hours. So that is statistically significant, but it is also likely clinically meaningful. Even more striking, nearly 1 in 4 patients with Popliteal Plexus Block group required 0 opioids. Let's talk about pain scores and the reality check. Here's the nuance. Despite the lower opioid use, however, in this study, there was no difference in actual pain scores at rest, during knee flexion, or during mobilization. The pain was already mild across all the groups. So the question is, what's going on? Well, this was not a pain score study. This was an opioid-sparing story. And let's briefly touch on motor function and mobilization, because this is where many clinicians worry. The posterior blocks behind the knee raise red flags. Will there be a tibial nerve involvement? Would there be a foot drop? Would there be a delayed ambulation? But in this study, there was no impairment of ankle plantar flexion, no impairment of dorsiflexion. There was no difference in quadriceps strength, and there was no difference in time up and go performance. So the Popliteal Plexus Block was actually motor sparing, and that matters. So the question is, how does this really compare to iPACK? Well, these are a few important distinctions. Number one, iPACK injects directly into the popliteal fossa, but the Popliteal Plexus Block relies on a proximal spread alongside the femoral artery. And this trial suggests that the high-volume Adductor canal block does not reliably substitute for Popliteal Plexus Block. You actually have to target the popliteal plexus if you want the effect that is exemplified in this particular study. And that may explain why iPACK data has been so heterogeneous. So these are the 5 top clinical takeaways from this study. Number 1, posterior knee pain contributes meaningfully to opioid use after TKA. Number 2, adding a Popliteal Plexus Block reduces 24-hour opioid consumption. Number 3, pain scores may not change, but the opioid exposure does with the Popliteal Plexus Block. 4, motor function and mobilization are preserved. And finally, number 5, the Popliteal Plexus Block may be a valuable adjunct, but not a replacement in motor-sparing TKA pathways. The bottom line is the Popliteal blocks doesn't make patient pain-free, but it does something arguably more important. It reduces opioid exposure without sacrificing strength or mobilization. In an era where opioid minimization matters, this study gives us a clue, a new tool, that when used selectively, thoughtfully, an evidence-based popliteal plexus block may be valuable. Until next time, stay sharp, stay evidence-based, and stay curious. Dr. Hadzik signing off.